Good afternoon, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with the Base Hospital Program. I believe we have a few people online today. So today we're going to have a webinar on last year today. So we're going to talk about last year's Recert and the results of that Recert before we head into Recert season this year. Okay, hear me? Didn't think so. If anyone can hear me, can you guys just send me a quick question in the question box on your toolbar and let me know that you can hear me? We're running into some mic difficulties. Dusty, does that mean you can hear me?
How about now? How about now? Hear me now?
Ah, beautiful. Okay, thanks, guys. I'm actually going to stop the recording and then re-live. Keep in mind, though, that the medical director and our medical director in charge of education, and Mike Rumble, who's one of our
Hello all. Oh wow, that's pretty loud. Let me just adjust that a little bit for you. Hello all, my name is Mike Rumble. I'm a pre-hospital care specialist here at the Base Hospital Program.
Matt Davis, thanks for joining us today. And as Steph said, we're just going to kind of touch on some new things from last year's Recert, so the ALS PCS 3.3. And as most of you are well aware, there will be a new release of the ALS PCS version 4. But today we're focusing on kind of what was new from last year, and which will be in practice up until the in-force date for ALS PCS 4.
Yeah, exactly. So the purpose of today's webinar is to review the changes that occur over the past year. And really this kind of came out of a lot of feedback from you guys, and especially actually as we were, because of course I'm a new pre-hospital care specialist here, so as I was going through this year's recertification process development, a lot of the feedback was that the paramedics wanted a review of last year's, especially coming into this year's recertification. So just kind of a reminder of where we were, where we are, and where we're going. So that's what we're going to do here.
A couple of these directives, they're low frequency types of calls, so your emergency dialysis disconnect, and as well as hyperkalemia, and we've put a few stats on that. So again, when you learn something new, it's very easy to kind of forget things as if you're not employing that all the time. So today's goal is to try to rehash and re-highlight some of those things from these directives, just to provide a bit of a refresher.
All right, so kind of the format that we're going to use in this going forward for each topic, and as you just saw there, the big 3 topics that were new were the opioid, the dialysis disconnect, and the hyperkalemia. For each of those, we're going to talk about what's changed, what the key teaching points were, and then kind of the feedback that we have after reviewing some of those calls. And then that's going to kind of proceed through each of the topics as we go through. So first and foremost would be opioid toxicity. This was a new protocol for PCPs, and for all paramedics, we got a new route of administration in intranasal administration. As a reminder, and on your screen there, kind of the typical triad of opioid toxicity is altered level of care, or sorry, altered level of consciousness, respiratory depression, usually some level of pinpoint pupils or meiosis, and then of course within the protocol as well, the inability to ventilate and the suspected opioid overdose being your major indications.
Yeah, and a question that's often asked is, why the inability to adequately ventilate, and why is that indication in there? And this was built in there as more of a safety mechanism for our paramedics, given the fact that with Narcan, most people can wake up gently, but there are those people that can become quite aggressive. So if a person or a paramedic is able to adequately ventilate the patient, then there's no need for Narcan, because remember, the reason we're giving Narcan is to increase their respiratory rate. It's not to wake them up completely, it's just to get them breathing. And oftentimes people get angry when they wake up completely because they've spent a lot of money on their high, and now you've taken it away from them. They can be quite aggressive. So that's why that feature was built into this directive.
Yeah, so I mean, just looking at the screen here, the other things, of course, looking at the other contraindication, obviously we always put in the allergy, but just keeping in mind that people who are altered level of consciousness, there may be multiple reasons for that. So just making sure, once again, and as paramedics, we're always reminded to check the sugar, but just make sure that there's not an easier fix for their lack of consciousness. So in this case, a low blood sugar. Your dosing is fairly easy at 0.8 across the board, unless they're getting IV naloxone, in which case it's 0.4 milligrams. And of course, there's a mandatory patch point in the PCP algorithm as well. All right. So yeah, just that, the mandatory patch. And in order of preference, subcutaneous actually is the preferred route, as is supported by literature. And then, of course, the IM, intranasal and IV routes. But again, a lot of this goes back to provider preference as well. And we realize that you guys are the ones out in the front line providing patient care. And in that situation, having a sharp out may represent a safety concern. So we do put that back to the paramedics to decide what they feel is comfortable and what they feel is safe for them.
Exactly. I mean, there's pros and cons to each route of administration, and you can't write a directive for each patient encounter out there. So yeah, although the preference is the directive state is kind of from left to right, again, we realize that every situation is going to be unique, and we'll leave that for you to decide as to what route you think would benefit yourself as well as the patient the best.
The other tip that I would have for giving Narcan in the opioid overdose is just to give that slowly, and then the titration of 0.1 milligrams at a time in order to kind of allow the patient to wake up slowly. And what you're really looking for, the key feature here, is to bring up that respiratory pattern, right? So if you can get them up to a respiratory rate greater than 10 that's helping support their own breathing, then that's the optimal dose for that patient. And then the dose is up to 0.4 milligrams for IV administration.
Again, just being aware for those PCP paramedics out there who may have not used this protocol yet, or may have only had a limited exposure to it. Again, we want to make sure that you're safe out there, so be vigilant that these patients can become aggressive, and if you're in a confined space. So again, that's the goal, is to just get their respiratory rate greater than 10, not to wake them up completely.
One last caveat that we have written down here, and obviously this has been big in the news lately, not only now can people who are at high risk of overdose obtain naloxone from public health, but they can actually go to a pharmacy now and get naloxone for free to have on hand in case of an overdose. So just to remind everyone that the dose of this and any other medication that we carry now is independent of previously given dosage. So if you show up on scene, they've already given their own dose that they got from public health or from the pharmacy. You are free to go ahead and give another dose if the patient still meets the criteria as outlined in the protocol. So feedback, especially on the PCP sides of things, because this is where the new part came in. So the first 6 months of the of implementation, this naloxone protocol, we had 11 cases where PCPs had given naloxone. 10 were for a known prescription medication use or abuse, and the last one was for an unknown, which is kind of interesting to see that all of this was for prescription medication. None of them, and I'm going to say none of them only because I don't know what the last one where it was an unknown etiology was. None of them actually had to do with kind of street drugs, heroin, or anything like that. It's all prescribed fentanyl or Dilaudid or oxys or whatever the the drug of choice is here. 2 of the cases had no patch, which may be a documentation issue, or maybe where the paramedic had a deviation from protocol, but it really kind of so far kind of a good start.
Yeah, so I mean, in terms of the patching, again, we're going to be patching for this directive up until 4.0, but until that time, as PCPs, and the patching is going to remain. Again, it's a bit of shared decision making with the physician. It was again another built-in safety feature there. Again, just to ensure that paramedic safety was kind of put as a priority with this, just to help along with that decision making and how much potential Narcan to administer to the patient.
So we move into the poll part of our thing here, and we have a poll question here. Should be up on the screen there. 28-year-old male, cyanotic, respiratory rate of 6, pinpoint pupils. It's very obvious that there's an opiate given, and they've already received a naloxone kit provided by Public Health. The poll is now open, so of the list there should be option A is patch for naloxone 0.8 milligrams sub-Q IM or intranasal, or 0.4 IV. Second option should be 0.4 sub-Q IM IV or 0.8 intranasal. And the next is don't give her Narcan. It's already been given. And the last one is give it, you don't need to patch. And keep in mind, again, this is as of the current directives that we're dealing with, and not the new ones that will be coming out next year.
All right, so I'm going to go ahead and close the poll and then share the results. So it looks like we've got 75% of you choosing to patch for naloxone.
Looks like we are sharing the poll results. I don't have those results. Oh, there we go. 75% of you chose patch for naloxone 0.8 milligrams sub-Q IM or IN, or 0.4 milligrams IV. 25% just chose that next option down. Well, it's true that we double the dose for intranasal. In this case, it's also subcutaneous and intramuscular injections as well are the 0.8 milligrams, and it's only the IV dose that is 0.4 milligrams. So that's how that works. Thank you. Next poll question, just kind of our segue, is home dialysis is often used for what condition? We have diabetes, hypertension, heart failure, or renal failure. We're waiting for, oh, we are closed. Yep, okay. And 100% of you got renal failure, so that's good. And, you know, I guess the splitting hairs on this particular question is that a lot of these conditions may lead to renal failure, and I think that's kind of the whole kind of preamble here is just saying that a lot of things can lead to renal failure, but ultimately that's when the kidneys fail is the point where they get put on dialysis. So the next thing that we're going to talk about then is the emergency dialysis disconnect, and this was a new directive for all paramedics, and that was identified because as more and more of the in-hospital or traditionally in-hospital procedures are moving out to the community, we as paramedics need to be able to respond to that, and we need to be able to provide appropriate care for people who are on devices that we previously haven't seen in the community or may have been very much hospital-based, and dialysis was identified as one of those problems. And oftentimes these patients may actually be alone or may not be able to disconnect themselves. Renal patients are at a higher risk for suffering a medical emergency, so perhaps somebody's at home, they suffer a medical emergency, they hit their little calling button, and you're required to respond.
Again, this is a low frequency call. I'm not sure if we've had any within our region since this directive was released. Again, most of the time there's going to be a family member, the patient themselves are going to be able to disconnect them themselves. This is, again, the key with this being an emergency when there's no one else around and you need to get that patient off the dialysis machine. This is what this directive was designed for. So it's probably going to be a once in a career, if that, for most of the medics in our region.
Yeah, absolutely. I guess taking the dialysis machine with you in the ambulance isn't really the option we prefer here. Now, that being said, the whole procedure can seem daunting. I think at first glance you think that it's maybe a little bit difficult, but it really isn't that difficult. It's no different than separating a child from mother at birth. You clamp on either sides of the umbilical cord and separate in between, and that's really what we do with the dialysis disconnect. So we're going to spend a few minutes here just talking about the procedure using the lovely pictures that were provided by CPR. So in this, we're looking at the peritoneal dialysis and dialysize. I don't know, how do you pluralize dialysis?
Dialysis.
Dialysis. All right, often. So you have your continuous cycling peritoneal dialysis or your continuous ambulatory peritoneal dialysis. Either way, the important part here is the catheter goes into the stomach and the peritoneal cavity is used as part of the dialysis process. With separating them, there's the two methods that you can see on the screen there, and the cycling is on my left, depending on what you're looking on the screen, the CCPD, and the ambulatory is going down the other side, the CAPD. So when you see each step, they kind of separate out to each side there. Each one has a clamp. The cycling peritoneal dialysis has the little white clamps, and the ambulatory dialysis has the red clamps there. So you clamp them off.
And depending on the manufacturer, I mean, the clamps are going to look a little bit different, but at the end of the day, they should have clamps provided with them.
Yep.
And just for clarification for peritoneal dialysis, so it's actually not into the stomach, but actually the peritoneal cavity, which there was just a slip there, but the dialysis actually bathes the peritoneal cavity.
True, yes. Stomach and more the common layperson
description of the abdomen,
the abdomen, yes. So at that point, there are caps generally with the machine. There's usually a little kit that's attached to the machine, and that probably should have been our first thing. There's usually a little emergency disconnect kit attached to the wall there. So within that kit, you'll see some caps there, and you can get the cap there. So you've clamped it on either side. You've disconnected it between the patient and their abdomen and the machine, and then you use the included cap, which is sterile. And when you're opening the sterile package, just attempt to be careful not to touch the inside of the cap in order to maintain as much sterility as we can. And that's pretty much it for peritoneal dialysis. At that point, they are capped off. You can take the patient and leave the machine behind. Now, within hemodialysis, so you may actually see hemodialysis in the home as well. Not, in my experience, not as common, but that being said, it's still out there. If it's hooked up to a graft or fistula, that's appropriate for all levels of paramedic to disconnect. If it's into a central venous catheter, then according to the protocol, that's only for advanced care paramedic disconnecting. Only advanced care paramedics are technically allowed within the regulation to access central venous devices. But that being said, the process is very much the same. You clamp using the included clamps on both sides and use the included caps in the set. And then the other part of all this is just kind of taping that whole area up to make sure that the site itself does not get damaged. And once again, with all dialysis, if you see a graft or a fistula, you're not going to be using that arm for a blood pressure or anything else to put an IV in. We're not sticking an IV in these sites. We're not using any of that. So the feedback for this, unfortunately, means that we have not seen any yet. If you have any feedback that you want to give us, if you know of somebody who's done one, or if you've done one yourself and we just missed it, feel free to pipe up and give your 2 cents. We're definitely looking for some feedback around how paramedics are doing with the dialysis disconnect.
And at this year's Recert, we do have a bit of a refresher, hands-on refresher with the emergency dialysis disconnect, where we have some of the equipment just to go over it again, where you can visualize it for the disconnect if needed.
So the next thing that's changed, if we don't have any other questions, we're kind of plugging along here. Hyperkalemia is a new protocol for ACPs, and we'll just take a few minutes to go through here and talk about both kind of what led to it becoming a protocol and how that works in relation with the rest of our protocols. So in this case, we're looking for kind of an arrest or pre-arrest patient who has, I kind of think of the protocol a little backwards from on screen. I'm looking for an arrest or a pre-arrest patient who has a high probability that this might be due to hyperkalemia. So they're on dialysis, or they have renal disease, or there's another reason why they may have hyperkalemia. And the example that they give here, of course, is crush injury. Let's see, move on there. So it's important to remember the purpose of the medications that we give for hyperkalemia. We've added in calcium gluconate, but we also have medications that on the truck that were good for this as well. So the approach should be not thought of as one or another. So you're not really giving one medication for hyperkalemia, but rather it's a multifaceted approach. So you're using a number of medications together to help lower that potassium. When we're doing that, there's three ways of dealing with potassium in the system. You can either shift it from the blood vessels into the cells, you can bind it, or you can excrete it. And that's really the three ways. So in saying that, we can attack it with the medications that we have on hand here. So calcium gluconate protects the myocardium and then reduces the ECG changes associated with hyperkalemia and could possibly prevent your patient from slipping into a life-threatening dysrhythmia, whether that's a widened QRS sine wave or into a ventricular rhythm. So it increases the threshold potential and restores the normal gradient between the threshold potential and the resting membrane potential. That's what's all messed up in hyperkalemia. So it, at a very basic level, it's just going to help stabilize the myocardium, and that's the important part to giving calcium gluconate.
You can think of calcium gluconate as it's protecting the heart. It's protecting the heart from going into any lethal dysrhythmias to help prevent that from occurring. So, ECG changes in keeping with hyperkalemia, calcium gluconate, that's just going to protect the heart. It has actually no effect on moving the potassium, and that's what these other medications, which Mike is going to discuss.
Yeah, absolutely. And that's the important thing to remember. So in this case, we're protecting the heart, but we're doing nothing about the potassium. So then let's talk about what can we do about the potassium as well. So we also carry Ventolin, and while we have long thought of Ventolin as a respiratory drug, it has a number of other side effects which are useful in this case. Most importantly right now is that it's going to shift the potassium into the cells and out of the blood. So when we're giving the Ventolin, we're giving a decent dose of Ventolin in this protocol, then we're going to be helping move that potassium into the cells. Now it's still in the body, so that's important to remember as well. And at some point it's going to come out of the cells. But from a paramedic point of view, that's going to take a few hours. So we're going to give our 16 puffs of Ventolin. We're going to be able to temporarily shift that potassium into the cells and at least get it out of the way and out of our minds for a few minutes while we get that patient to the hospital. The only contraindications for calcium are patients on digoxin. And of course, this is a mandatory patch. So when we're patching, we're often going to be talking to physicians about this patient. We're going to have to paint that picture of why we think that this patient has a hyperkalemic arrest or a near or pre-arrest. And we're going to be kind of discussing with them the treatment options. It's important to prompt them as to what the protocol that we have is, because everything has kind of a number of approaches that the physician may normally take in their own practice. So we're going to take the approach that is in our protocol, and they may have a slightly different approach. So they may give orders for other drugs as well on top of the calcium.
Yeah, so I think when you're calling for this directive, the request should be kind of upfront. I'm calling for hyperkalemia directive. I'm looking to give 1 gram of calcium as well as 16 puffs of salbutamol for this patient. And as Mike said, there are various practices out there. So you may, when you request this, the physician may give you some additional orders on top of this as well. But I think if you frame the question as the protocol is directive, a lot of the physicians will say, yep, go ahead with your protocol.
Yeah, absolutely. So just to take a minute, and the reason I guess that we're talking about all this is because we're going to talk about the actual review of the cases where we've given it, and there's been a number of variances from the protocol that's within the medications that we give. So the first, of course, is sodium bicarb, which has been administered in the past for patients with hyperkalemia, and it may have a role, but in the pre-hospital world, it really doesn't have a role. Of course, sodium bicarb itself is going to shift potassium from the bloodstream in the cells, but it's mainly binding the acid where the effect of sodium bicarb comes into play. So you're a profoundly acidotic patient on top of the hyperkalemia. The problem with giving sodium bicarb is that not only do you have those good effects, but you also have the potential downside of respiratory depression, pulmonary edema. There's a lot of play there where the benefit for the short period of time where the paramedic has the patient may not be worth the risk of giving the drug.
Yeah, so the latest research and meta-analysis of all the studies out there shows that sodium bicarb may have a minimal effect in patients who are acidotic, and oftentimes it may be difficult to determine who isn't acidotic in the pre-hospital setting. But again, as Mike said, there's also some side effects with pulmonary edema, and again, these are patients who are most likely dialysis dependent, if not have very poor kidneys. And the effect with sodium bicarb is that it is a very hypertonic solution. So what will happen is you're giving a high load of sodium, and as you give high amounts of sodium, water often follows that sodium. So oftentimes these patients may have a degree of pulmonary edema already occurring. Now we're giving them sodium bicarb, which may worsen that pulmonary edema. So again, that's why the sodium bicarb is not built into the protocol, but in discussing the case with the BHP, this may be a patient who may be a candidate for sodium bicarb, so you may receive the order for sodium bicarb for these patients. So don't be surprised if you do, but don't be surprised if you don't. It's going to be kind of a case-dependent type of patient.
All right. So with hyperkalemia, just kind of keep in mind, and actually on the screen here, it's actually not quite in order here. The order of ECG discrepancies tends to be, you see the peak T waves first, then you lose the P waves, and then you kind of get that widened QRS moving into the sine wave pattern that you also see on the screen there. So you may see them at any point during that continuum. So it may be right into the widened QRS progressing into the sine wave pattern, or you may have it relatively early on where it's just the peak T waves. You're taking this information in context with the entire patient presentation though, right? So you're keeping in mind that they also have the history of renal failure and are on dialysis already.
Yeah, unfortunately there's no serum correlation of the potassium level with these ECG changes. So someone who may have a level of 6.3, which is a critical level, may have some quite concerning findings on ECGs, such as the widened QRS and starting to go toward that sine wave, versus someone who is used to kind of running with a higher potassium may have a potassium of 9 and only have peak T waves. So again, there's no correlation to the degree of severity of the hyperkalemia with the patient. So if you do have these ECG findings and you're suspicious for hyperkalemia, then yep, this protocol can be used. And again, in the VSA setting, you continue on with your normal cardiac arrest management. Get on the phone early to the BHP to discuss the case and receive the orders for the calcium gluconate and salbutamol.
So speaking of that, so some feedback here. When I put this presentation together, there had only been 6 cases. I think we're up to 7 now. And of course, those being both in London and in Windsor. And it was kind of interesting to go through this, like personally from my perspective, just to see the variation in approach, both by the paramedics and by the BHPs that were being patched to. And not only that, but then the actual implications for practice. So for example, giving 16 doses of Ventolin was somewhat problematic when you're also trying to get the patient packaged. They may be in an arrest state, giving it through BDM, whatever the issue is, right? And getting them to the hospital, and meanwhile every few seconds trying to recharge and give another dose. So that was kind of an interesting process going through. In some cases, bicarb was given as well, and we just talked about that and why. In some cases, Ventolin was not given, or was given at a reduced dose. And again, there was a lot of, in talking to the paramedics, there was a lot of kind of discussion around how to achieve that dose while keeping all of the other priorities in mind. The other part which was interesting was the variation of calcium gluconate dosing between 1 and 2 grams in a single dose or in divided doses. In all of the cases, they were all VSA or became VSA very quickly, except for one. So they were all either immediately pre-arrest, or they, in the majority of cases, they were already in arrest. Okay, and once again, a reminder: if you want to ask questions, feel free to ask questions in the chat box or question thing. So we have another poll question. So a 65-year-old male has a history of diabetes, renal failure, and depression. You see this ECG, and what could be the possible answers? What could be causing this? You got TCA overdose, hyperkalemia, STEMI, and an anti-malarial overdose. And the poll is open. And the poll is closed. Everyone chose hyperkalemia. I will say, however, this is a bit of a trick ECG. There's a number of correct answers for this, and the point of that was just to say that the diagnosis isn't made on the ECG alone. It's taken the whole clinical context into account.
Yeah, that's it exactly. I mean, you got a limited history here. You've got ECG changes, which very well could be hyperkalemia, but they could also be related to a TCA overdose. So again, it's going to be putting all the pieces of the puzzle together, and the ECG findings are just one piece of that puzzle.
Okay, so moving on. Illalgesia Protocol, what was changed? So basically this was moved from auxiliary medical directives into core medical directives. There's some Ketorolac dosing changes. It went from 30 milligrams down to 10 to 15. And we removed the restrictions for age less than 50 for all the NSAIDs, so Ketorolac and ibuprofen. And the other large change that occurred last year was the removal of fentanyl from the ACP directive. So you have the protocol there on your screen. Again, we've talked about the major changes here. Keeping in mind that the difference here between the mild and moderate pain for the Tylenol-ibuprofen combo, or the mild to severe pain for Ketorolac, and when the patient's unable to take oral medications. There's not a lot to say kind of about the contraindications here. We've talked about the changes that occurred over the last year with the removal of the age greater than 50 from that, the change in the dosing for Ketorolac.
The change of the dosing is a result of the research shows that the side effects with 30 milligrams of IV Ketorolac, much more than that with 10 to 15, but the amount of analgesia received between the doses of 10 to 15, between that and 30, really wasn't that much different, but the side effects do become quite more significant with the dose of 30, especially in the older patient population. So that's why there's been the change down to 10 to 15 milligrams. I'm sure many of you still see within the emergency departments larger doses being given. I remember as a medical student we were giving upwards of 60 milligrams at one point. I think, you know, the knowledge translation, I think you guys are more ahead of the game compared to some others. So I think, you know, over time you're going to start seeing even the practice within the emergency department of smaller doses of Ketorolac being given. I know I've changed my practice based on this, and definitely with the elderly I'm giving doses of 10 to 15 milligrams IV or IM for them.
And again, most of these changes translate all equally as well into the primary care directive as well. So I guess the point that I would want to make with regards to the primary care directive, and actually at the advanced care level as well, is the efficacy of the Tylenol ibuprofen combo in relation to the Ketorolac. And I think kind of even now it's still very much impressive to give a drug IV or IM or to put it in a syringe and give it, but the efficacy of the Tylenol ibuprofen combo PO is actually really good, and it's not something that kind of should be looked down upon as a lesser drug. It's a very effective way of treating pain.
Another frequent question that comes up is the indications there with isolated extremity trauma. So the question becomes, well, you know, what happens if they have a broken wrist and a broken ankle, or an ankle sprain and a broken wrist? What does isolated mean? And isolated just means isolated to the extremity. So I mean, you can think of extremities as opposed to extremity there, but if they've got, you know, a polytrauma patient with you know, central type of trauma, abdominal chest trauma plus a hip fracture, then again that would not be the indication for it. So when they say isolated hip or extremity trauma, you can have, yes, more than two extremities involved.
All right. So the last kind of point that I was going to talk about with all that, we've talked about most in all of these already, is just that the whole unable to take oral medications. And really, at the end of the day, that's going to be up to you as the provider to say whether they can or cannot take. I mean, obviously, it's the patient's preference. You're going to ask them whether they're able to tolerate oral medication. But when we're reviewing the form, it's just going to be up to your description that the patient wasn't able to tolerate oral medications, and then that's going to be the deciding factor. So some feedback that we've had about this. Sorry, we're going to kind of cut through a few of those screens quickly. They're a lot of the duplicate of the advanced care protocol as well. And the same teaching points obviously apply to Ketorolac, ibuprofen, and acetaminophen. So a few of the feedback from audits. A few times NSAIDs are listed under medications, but there's no reference to when the last dose was. And just a reminder that the NSAID can't be given within 6 hours of the previous NSAID. So just remember to document that there has been no use in the last 6 hours. Anticoagulant therapy is always a hot topic. So that's
So when it comes to the anticoagulation therapy as a contraindication, so we're talking about warfarin and your newer anticoagulation medications such as Pixaban, Bigatran. That's an anticoagulant, and whereas there's antiplatelet agents, which is not an anticoagulant therapy. So that's just sometimes people forget that Plavix, clopidogrel, is an antiplatelet medication, not an anticoagulant.
Perfect. I lost my point there, but
and there is within our website there is the med list, which outlines medications which are anticoagulation. So if you need a reference, that's a great reference point that you can use to see which are anticoagulants versus which are antiplatelets.
And just the last 2 points there, which are documentation points. If a patient has pain, then there should be some pain assessment associated with that, so we can help kind of quantify that later on. And the last point is just that drug doses should always be documented in the dose delivered, not in the volume of medication delivered. So as you see on the screen there, 15 milligrams versus 0.5 mils. You would always want to document your drug dosages as the dose administered.
And there's a great little feedback there just to help with the auditing process. If it's documented correctly, then you won't get the email coming to you asking about clarification. So just some pointers just for your documentation purposes, just to avoid those emails coming to you.
Awesome. So another poll question coming up here. Oh, I clicked on the, there we go. What do you find most effective for pre-hospital analgesia of isolated limb fracture, closed or back strain? This is actually very much, I just want to know what you think. This isn't a right or wrong answer. So there's a bunch of you out there. Tell us what your feedback is, what is good in your practice. All right, our poll is closed, so hopefully a good number of you have gotten into it. And it's interesting that 29%, so we're almost at like 2/3 and 1/3, almost, where a good number of you are finding effective pain relief with the Tylenol and ibuprofen combo. And then, of course, as expected, a majority are finding good analgesia with the Ketorolac.
Which is very interesting because when you look at the literature out there, there's actually no class specific, so Ketorolac, ibuprofen, when you look at these medications in a research setting, when they control for all the variables, there's actually really no difference between Ketorolac and ibuprofen. So, a big thing with pain management is that multifaceted pain management. So using multiple different medications which are going to act in pain in different ways is actually found to be superior than to unimodal, so giving the one medication. So oftentimes, with pain, we want to hit it from all different ways with medications, but then also those, from an emergency standpoint, there's also those non-medication ways which we want to help with pain as well. It can be simple as things as heating pad, ice packs, depending on the injury at hand.
Yeah, absolutely. And that's a great reminder for everyone that we also have those kind of not-so-medication ways of dealing with pain, the ways that we used to have to do before we had drugs for this. And
you often wonder about the placebo effect, too, with an injection. So, patients think, I'm getting an injection, so therefore it's going to be a better pain medication. Again, when you look at the literature, they actually control for the IM versus IV injections when they look at the differences between ibuprofen, Ketorolac, or any NSAID, acetaminophen. So they control for those factors. And I do believe there's probably a bit of a placebo effect with the poke and the deltoid. But then, yeah, they're left with a sore deltoid for the next couple of days.
That's right. That pain's worse. All right, so this is kind of the last part of the changes here. Some very minor changes. They all got included on one slide here. There were just some clarifications regarding contraindications for pediatric analgesia and cardiogenic shock. They changed to include adults, so greater than 18, for both the fluid bolus and the dopamine. And those were the last two changes. Kind of the last two big changes that were in last year's recertification section. If you have any questions, we're going to give you a few moments here to type them up because this is it. That being said, while I'm letting you guys write all of your wonderful questions into the box there, there is some other options here to contact us. Maybe you don't feel like participating in a public forum. You can use the chat box to ask now. As always, there's the companion document, both for ALS PCS 3.3 and then the upcoming 4.0. We'll have the companion document to describe the reasons why. You can go to the Ask Mac website, and that's an awesome resource. And a lot of the information that we pulled from for this presentation came from there. As well, you can contact us either through our office number or through the self-report communication line. The link is on the screen. It's also on their website. And again, if you ever want to know where the website is, just Google SWORB because nothing else on the internet is named SWORB. So it's the first result. And then there's the self-report 800 number.
So just want to thank everyone for joining us today. We'll be covering some of these topics again at the upcoming Recert. And just as a reminder, this is kind of the 3.3 for those who've already had their Recerts and have learned some new things regarding these directives. Again, this is a rehash of what's to be practiced until the ALS PCS version 4 and 4.1 go into effect, which we're still waiting on that date, but until then, it's practicing as you would. Thank you.
Thank you.
All right, big thanks to Matt and Mike for the presentation. Keep an eye on your email, guys, because we do have a number of webinars coming up before Christmas. Once again, thanks for attending.